Good evening, I'm Dr. Baldini, anesthesiologist and medical director of the Montreal General Hospital Preoperative Center at McGill University. These are my disclosures. I receive honorarium and consultant fee from Merck, Edward Life Science Canada, and Abbott Nutrition.
Before starting to talk in the next 10 minutes about the most beneficial perioperative strategies to mitigate infection risk, I would like to remind that the several perioperative risk factors contribute to development of postoperative infections. Therefore, the implementation of not only preoperative intervention, but of a bundle of perioperative intervention is likely to reduce postoperative infection risk. Moreover, it is also important to remember that the development of postoperative infection is a surgery and clinical context specific. In fact, while for certain surgeries some perioperative factors have shown to predict postoperative infection, for others, the exposure to the same risk factor has not been associated with postoperative infections. Similarly, exposure to the same risk factors during elective or emergency procedures has demonstrated different association with postoperative infections. It is well demonstrated that smoking is associated with postoperative infections, in particular surgical site infections and pneumonia, as demonstrated by the results of these two meta-analyses, including large observational studies conducted in patients undergoing different surgical procedures. As a result, several trials have evaluated whether preoperative smoking cessation improved postoperative outcomes. The results of the latest meta-analysis pooling 4 randomized controlled trials performed in patients undergoing orthopedic and abdominal surgery have shown that preoperative smoking cessations reduced surgical site infection by 60%. It is important to highlight, though, that these results were driven mainly by the results of one randomized controlled trial conducted in patients undergoing orthopedic surgery and receiving intense preoperative smoking cessations. In fact, as other studies have also demonstrated, only intense preoperative smoking cessations program, including a duration of minimum 4 weeks, pharmacotherapy, and individual counseling, have shown to reduce postoperative complications compared to single intervention of shorter duration.
Similarly, it has been demonstrated that alcohol overconsume inhibits the cell-mediated immune response and it is associated with a higher risk of developing postoperative infections. Available evidence shows that the 1-month preoperative alcohol abstinence program, including patients' education, pharmacotherapy, and relapse prophylaxis, significantly reduces postoperative infections, as demonstrated by this meta-analysis pooling the results of 4 randomized controlled trials conducted in different types of surgeries. Despite preoperative hemoglobin levels are measured in the majority of surgical patients, anemic patients are rarely optimized. Anemia is present in up to 60% of surgical patients undergoing non-cardiac surgery, and it is associated, even mild anemia, with increased allogenic transfusions and adverse outcomes such as mortality, morbidity, and prolonged hospital stay, including infections. Similarly, perioperative bleeding and allogenic blood transfusion are also both associated with increased risk of infections. Correcting preoperative anemia is recommended for every anemic patient undergoing elective surgery, as anemia correction is associated with reduced allogenic transfusions. However, if preoperative anemia optimization specifically reduced postoperative infections and independently from reducing allogenic blood transfusions remains unproven. Last year, the results of the largest multicenter randomized controlled trial, including almost 500 anemic patients scheduled for elective non-cardiac surgery, were published. The PREVENT trial tried to establish whether preoperative IV iron infusion in this population would reduce the composite outcome of mortality and allogenic blood transfusions. The results of the PREVENT trial did not demonstrate the expected benefits of preoperative IV iron infusion, as there were no difference in the primary outcomes between the two groups. Moreover, the trial was not powered to detect a reduction of postoperative infections. However, it is interesting to note that although significant postoperative complications defined by the Clavien-Dindo grade 3 and above were not reduced by the intervention, the number of patients readmitted at 8 weeks and at 6 months with postoperative complications were significantly lower in the intervention group. Among the most common reasons for readmission at 8 weeks, the authors reported general postoperative complications, 15% in the placebo group, versus 11% in the intervention group, general infection, 3% in both groups, and wound infection, 3% in the placebo group and less than 1% in the intervention group. It is well established that malnourished patients have a significantly greater risk to develop postoperative complications and die than well-nourished patients. Also, extensive evidence demonstrated that treating malnutrition preoperatively significantly improves postoperative outcomes. In fact, among 120 severely malnourished patients identified by a nutritional risk screening score above 4 and undergoing elective abdominal surgery, those who received preoperative nutritional optimization had a significantly lower risk to develop postoperative complications, including infectious and non-infectious complications. Importantly, the duration and the quality of the intervention also significantly impacts on postoperative infectious complications. In fact, among patients undergoing elective gastric resection for gastric cancer, as the duration of nutritional support increases, the occurrence of surgical site infection is more likely to decrease, and a nutritional intervention period for at least 10 days is associated with a significant reduction in the incidence of surgical site infections in comparison to patients receiving no intervention or inadequate energy intake. Furthermore, no patients with a nutritional intervention period longer than 10 days develop serious surgical site infections. Moreover, the incidence of surgical site infection was significantly lower in the group receiving adequate energy support via oral, enteral, and/or parenteral nutrition for at least 10 days than in the group with inadequate support for less than 10 days. Finally, this study also demonstrated that a well-managed preoperative nutritional support was an independent factor associated with fewer surgical site infections. For these reasons, the American Society of Enhanced Recovery has recommended to screen for nutritional risk and malnutrition every patient undergoing elective gastrointestinal surgery with a preoperative nutrition score. It is recommended to administer high-protein nutritional supplements 2-3 times a day or immunonutrition to all patients with a PONS score greater than 1 or albumin less than 3 for a duration of at least 7 days. These should have a goal of delivering at least 1.2 grams per kilo per day total of protein as recommended by the American Society of Parenteral and Enteral Nutrition. These interventions have shown to significantly reduce postoperative infections in the context of traditional care and in the context of enhanced care for patients undergoing colorectal surgery. Moreover, as many patients, including not malnourished patients, do not meet their energy and protein needs from normal food, the consensus group suggested to consider, instead of recommending, using immunonutrition supplements in every patient in light of the inconclusive and controversial evidence about immunonutrition.
Similarly to malnourished patients, diabetic and non-diabetic patients with poor glycemic control, identified by high hemoglobin A1C values, cutoff ranging between 5.9 to 8%, depending on the study, have a higher risk of developing postoperative infectious complications after non-cardiac surgery, specifically after vascular, orthopedic, and colorectal surgery. However, despite this association and recommendation from different guidelines worldwide to optimize glycemia before surgery, studies demonstrating that preoperative glycemic optimization reduces postoperative infections are lacking. Recently, a randomized controlled trial assessed the impact of prehabilitation in high-risk patients scheduled for elective abdominal surgery on postoperative complications. Primary outcome: number of patients with postoperative complications. Patients were randomized to either standard of care or prehabilitation plus standard of care. Standard of care included nutritional and anemia optimization and smoking cessation. Prehabilitation included a high-intensity endurance training and promotion of physical activity.
The results were quite impressive and showed that aerobic capacity measured by endurance time significantly increased in prehabilitated patients. This improvement was associated with a significant reduction in patients with postoperative complications and in the number of complications per patient. When the authors looked at the type of complication in each group, there were less infectious and cardiovascular complications and less paralytic ileus in the prehabilitation group. Ultimately, the results of these recent meta-analyses, including 22 randomized controlled trials and 8 observational studies, suggest that in colorectal patients all receiving intravenous antibiotic before surgery, patients who also receive preoperative mechanical bowel preparation with oral antibiotic, either neomycin or metronidazole, have 55% less risk of developing surgical site infection in comparison to patients receiving mechanical bowel preparation alone. In conclusion, preoperative smoking and alcohol cessation programs of at least 4 weeks and consisting of multimodal intervention have shown to reduce postoperative infections. High-quality evidence supporting preoperative anemia and glycemic optimization to reduce infection risk is lacking. National Society recommendations supporting preoperative anemia and glycemic optimization are based on observational studies and expert opinion. Nutritional optimization reduces postoperative infections. Prehabilitation has shown to reduce postoperative infections. The use of mechanical bowel preparation, when indicated with oral antibiotic, reduces surgical site infection compared to mechanical bowel preparation alone. Thank you for your attention.